In my last presentation, what I sought to characterize was some distinctive features of what we call big data, and by extension, that subset of big data that we're really covering intensively in this boot camp, to wit, data recorded from smartphones on the one hand and wearable devices on the other. We will talk about how that sort of data can be cross-linked with some of the other data, such as social media data, browsing data, app use, etc., at a later time. But in this lecture, what I wanted to do was expand a little bit more about this theme that we had touched on at the end of that presentation, which is, okay, so we have these distinctive types of electronic data sources which can inform an understanding of health behavior, health exposures, context, the choices people make in health, etc. What are some of the compelling value propositions of this? How can that data be useful? So we're going to be talking about some of the types of insight that we're dealing with. And as part of this, I should note that we are interested in my work in addressing challenges of ever-growing complexity. So we spend a lot of time working with complexity in the health area. So these are systems which exhibit blowback effects where an action, intervention, a policy undertaking can sometimes trigger results that dilute or even reverse gains from the policy. An example would be here antibiotic resistance, or cases where by promotion of low-tar cigarettes to lower carcinogen exposure for smokers, we end up inadvertently discouraging quitting behavior. We're interested in cases where there are mutually interacting conditions where syndemics are illustrated. Merrill Singer, in his book Syndemics, is powerfully written about interacting epidemics that we see in many communities. For example, between substance abuse, violence, and addiction behavior on the one hand. These are coupled simultaneously health and social issues that are entangled in a notable way. Or the interactions of certain chronic and communicable illness. The fact that obesity and factors like diabetes, which are known to have adverse immune impact, can actually worsen the spread of communicable illness, for example. Increasingly, we're dealing with an aging population in developing countries, which suffers many comorbidities and what are called sometimes complex patients. And with a world that's increasingly interconnected, and where a lot of the boundaries between animal health and human health, and between health zones where different conditions apply are being lessened or erased. So this whole notion of One Health, for example, which has come to the fore, particularly about the animal-human interface, but also linking up epidemics in one area of the world, like the Zika virus, increasingly coming to others. Part of that is the rise of global travel, global trade, etc. We're also increasingly aware of intergenerational epigenetic effects in the long shadows cast by early life exposures. The fact that exposures in the very earliest years of life, even in utero, before someone's born, while they're in gestation, may have very significant impacts on their life course, perhaps not in a predetermined way, but in a way which makes them more vulnerable to certain later insults, and which alters the trajectory that they might otherwise have followed, although not in a totally rigid way. We're also dealing with a context, as many of those from health backgrounds are aware, where certain domains where we've long counted on safety due to advances in vaccine technology, for example, are now being called into the fore. So lower risk perception, the anti-vaccination movement has impinged upon, and in some cases threatened, herd immunity that's largely protected the population from childhood infectious diseases like pertussis and measles and chickenpox. Along the scourge that was later eliminated due to vaccination, but now recurring due to shortcomings in vaccination rate. Any insight into that, Merlin?
You're stuck where you are.
Okay. Okay. I can live with that for now. Okay. Thanks very much.
You're welcome.
We're also dealing with multi-outcome, multiple complication conditions. These multifactorial diseases like obesity, diabetes, which can come from multiple sources. And finally, in some areas, such as tobacco, we're dealing, in the food industry, we're dealing with ever more nimble corporate actors that mobilize to defeat things like taxes on sugar-sweetened beverages, that mobilize social media, online forums, to building up questions about the reliability of evidence of the health harms of smoking, etc. So we're dealing with a situation, in short, where there's complex health challenges. And increasingly we seek to define intervention strategies, policies, and treatments which are tailored to this complexity, so which secure a longitudinal perspective, a life course perspective in many cases, that seek to shape and exploit networks that are tailored or targeted to particular subgroups. We talk about precision medicine or personalized healthcare. There's a lot of hype associated with this, but the point is that we do recognize that different people are in different circumstances, and sometimes we need to tailor the intervention strategies to those characteristics. We realize the importance of context and relationships for affecting a person's health trajectory, the fact that they are influenced by their people in their social networks, and particularly proximate people. And are interested in incentivizing certain types of behavioral responses and learning rapidly from interventions and natural experiments and experiences. So our particular context that biases my viewpoint is coming to this from a perspective of rich simulation models to enhance decision making. And a common challenge that I noted in the last set of slides was the fact that reliable data on many of the key health behaviors or exposures are often hard to secure. Okay, a key challenge here is that absence and understanding of these behaviors, exposures, contexts, the potential for quantitatively evaluating certain types of policy trade-offs, particularly policy trade-offs that take into account kind of the behavior of individuals at a micro scale, is really challenged. And in many of our interventions, when it comes to preventing people from relapsing to smoking, to nudging eating behavior, to understanding the interaction of e-cigarettes and cigarettes, a lot of the insights have to do with factors of that micro behavior. I know that traditional behavior is becoming harder to secure in some areas, and certainly not any cheaper to collect using traditional instruments. So a reminder that this morning we spoke about the 4 V's of big data health: the volume, velocity, variety, and veracity of the data. And we're going to go on and talk about how these sort of levels of contribution end up affecting us at several different levels. Some of these levels have to do with the self-care. So helping people to better watch over their habits, highly motivated individuals often in this case, providing them a more perfect mirror of places where they're, say, eating healthily, where they're not, providing them a more of a summary of their exposures and experiences in a way that would be hard to get through simple memory. Perhaps it's tracking their physical activity or sedentary behavior over time, their exposures to certain types of environments, or their behavior at a small scale, and summarizing it up in a way that allows them to sort of take stock of it more clearly. Perhaps to better understand when are they falling short in terms of taking their medication for things like diabetes, for disease. When is it that they tend to forget? When is it that they tend to be more reliable? when is it that their blood sugar tends to go up in the light of their eating habits and physical activity in a way that might allow them to better care for themselves. This is addressing a fairly small segment of the highly motivated population, but in some cases individuals, particularly when contracting real threats to their health, are interested in really mobilizing their personal resources to care for themselves better and to care for loved ones better. And if you can provide supports for this sort of self-care and informal care of a loved one, say by a spouse or by a child, you may be able to extend their life, improve their quality of life in a notable way. Some of these tools that we talk about, by contrast, inform more the clinical management side, helping a clinician and allied health professionals understand the particular challenges a specific type of patient faces for self-care and informal care in terms of symptoms and context, in terms of care seeking. And an example of this that Tina's involved in here, and which is going to be bearing, I think, a lot of fruit over the next year, is our partnership with Regina Capel Health Region, again, for delivering insight to clinicians involved in managing the intravenous drug use population. And one of the observations these are HIV positive individuals specifically, and one of the observations there is that it makes all the difference once they have contracted HIV, how quickly they are diagnosed, but also how carefully they manage themselves, how reliably they're taking their medications, their antiretroviral cocktails, and so on. And if and the clinicians there are very interested in insights as to the particular barriers faced by certain patients so that they can be placed into management categories to better manage them, their interactions with the care system, to figure out, is this person someone I need to meet with weekly or only every quarter year or so. So clinical management, how do we manage different types of patients? How do we best manage this patient? What sort of characteristics does this patient who's just walked in the door for the first time have? That might help me as a clinician better manage their outcomes and better help them manage themselves. Better ensure the fact they'll come in and see me more, that they'll have the requisite health resources to manage themselves, that they're likely to be able to take their pharmaceuticals on a regular basis or engage in health behaviors supportive of their health outcomes. A separate domain, or a higher level domain in which we can help is by helping to facilitate health services deliveries, detecting bottlenecks and inefficiencies in a healthcare system, identifying key delays and coordination challenges that may be operating within a hospital or long-term care facility. So here, it's not just about helping one or a small number of clinicians, it's about helping coordination and effective system operation within a larger facility, say. So we may be able to identify places where there's a lot of unnecessary waiting of nurses for a consult with a doctor and help smooth that over. At a higher level up than that is sort of helping improve operational decisions at a system level, to help prioritize testing across different categories or identification of outbreaks, such as Ivan will be talking about in his work, faster identification of outbreaks and evaluating control strategies for those outbreaks. And then finally, strategic decision making, trying to figure out how do we best undertake policies or undertake restructuring of a healthcare system to yield the most favorable outcomes. So let's talk about some key use cases for mobile data collection tools. I challenged myself, could I put down a couple of contributions which I see as particularly key, where the benefits are particularly manifest? And here are a few. These are by no means exhaustive. There's lots of others, but these are ones I see on a recurrent basis. Number one, assessing the symptoms, particularly subclinical symptoms, which are often missed in traditional instruments. Cognitions and behaviors related to risk factors and exposures, okay? So here, we're trying to understand the ways in which a particular person's exposure over time to different environments might lead to symptoms that might fall below the level of what a clinician would normally pick up, a physician, but are really important to their health outcomes. Maybe these are suicidal ideations on the part of a patient that would otherwise go unreported or unnoticed. Maybe these are tobacco-related cognitions that might tempt someone to fall back into tobacco use because they're being bombarded by, billboards and gas station ads and product promotion in stores, and it ends up swaying them in their conviction on staying quit. Maybe these are exposures to health environments like adverse air quality, and it's subclinical exposures that really wouldn't bring a person to a doctor immediately, but are really important for understanding the situation. Maybe it's coughing and wheezing, right, in response to adverse air quality. So that's one sort of type of situation we see a lot. And in fact, several health studies that if you browse those sample studies, there are several of them that are focused on that. Reporting when I'm feeling some sort of symptoms of illness that might be relevant to my recreational water use, my use of the surf in California. Or maybe it's understanding symptoms that could be indicative, not necessarily that are, but could be indicative of foodborne illness. Here, these are symptoms that would otherwise go unnoticed. It's estimated with foodborne illness, something like 0.5% of all cases of foodborne illness are recorded by the healthcare system, but we can pick them up on a smartphone, which registers things. Yes, we'll pick up a lot of cases that are not, but by pairing that with data about where people have eaten and where others have eaten and whether they got it, whether they felt lousy, we might be able to zero in on an outbreak sooner. So that's one area, exposures and symptoms and cognitions and behaviors that can be self-reported. We can track a lot of the exposures automatically with GPS, with Bluetooth to discover others, and we can track symptoms and cognitions and behaviors with self-reporting. Here's another one. Enhancing the speed, reliability, and depth of learning from implemented interventions. I would argue that these tools bring us much closer to reasoning about what's going on at a mechanistic level, and they help us understand when we implement an intervention through what particular pathways we've succeeded in changing things for the better and where we've fallen short. And regardless of whether the intervention as a whole is successful or not in terms of nudging the key health outcomes of interest, BMI, level of physical activity, the point is with these sort of tools, mobile data collection, we can better understand through what pathways we succeeded in changing things and through which ones we did not, which causal pathways to that outcome. And what that means is even if the intervention as a whole fell flat, we understand better why and can formulate a better intervention on the basis of that. In short, we can learn more quickly from our mistakes or from our shortcomings so we can improve our intervention sooner. So we fail forward, as it said. We've tried something, we've learned from it, and now we can formulate a better intervention. Okay? A third thing is clarifying choice contexts and mechanisms that lead to different choices. So in different environments, people make different choices. Identifying which choice contexts and which particular factors in those choice environments lead them to choose one way or the other. Maybe it's to choose to take active transport versus take vehicular transport. Maybe it's that choice of what type of food to eat, or choose a choice of engaging in sedentary behavior or not. What sorts of environments and situations and factors in that choice context lead one to one versus other? And this can help uncover reveal preferences from from data, and we can elicit stated preferences on the part of individuals using survey questionnaires. And then finally, supporting a broader understanding of the texture of daily life for participants that raise challenges for compliance. So let's talk about these things. So symptoms and our exposures and symptoms. We talked about this before, right? Here we might have exposures occurring to water, for example, here, and then symptomology that often is not enough to bring someone to a healthcare professional, such as recurrent of this highly credible gastrointestinal illness, or HCGI. By understanding these patterns of exposure and outcomes, we might be able to recognize connections or at least associations that weren't obvious before. Here, this idea of a timeline by which we have outcomes manifesting is another component of this. This is some data from studies that Aydin has been working on. I don't know if Aydin is in the room right now, but looking at exposures to food at home or other places, and then occurrences of what may be cases of foodborne illness, you could try to understand the degree to which exposures of certain sorts, such as eating food from certain vendors, because we can track where they've gone, among other things, and then we can ask them to record when they've eaten, to what degree that's associated with an elevated risk of possible foodborne illness. This is something of considerable interest. It's an area where Arash here is likely to be contributing using a version of recurrent events analysis. Take a look at this data. So here we're leveraging the mobile technologies for reporting, yes, using buttons, reporting when they're feeling ill, reporting when they've been exposed to food, but they are further, we can also use GPS to track where they are purchasing food, etc. So they may record a purchase of food and we know where they purchased it using GPS. So we can look at this across multiple trajectories and perform the analysis. So, this might be the set of places people within this study have eaten non-home cooked foods. This is from, I believe, 80 or so person cohort that we followed for about 3 months for foodborne illness. This is the places they reported eating non-home cooked foods from GPS, right? And these are the places where they ate within 24 hours before reported illness, for example. So we could look at these possible connections here between these sorts of exposures and outcomes. If we're interested in kind of understanding the linkages between vendor illness and risk perception and food seeking and exposure to contaminated food, traditional data sources leave us with kind of blunt measures. The number of cases reported to public health or vendors identified later as contaminated, the weather information for truck-like vendors that might affect the illness. And if we have data from smartphones that we can use to complement this, we can fill in some additional gaps here. So we could start to understand subclinical illnesses as well as clinical illnesses. We can understand, food-seeking behavior and risk perception. We can understand something about their risk awareness and self-reported perceived risk using information gathered through the phone. In short, we can go from a situation with less information to more along these causal pathways. So how does this deliver value in different areas? Well, let's just think through some examples, okay? Of this example of subclinical symptomology and cognitions and behaviors in relation to exposures, for example. So we can ask for obesity, how do changes in a given person's target weight, for example, reflect the weights of those around them? There's some work by Ross Hammond along these lines has contributed a nice little agent-based model to look at this. And it posits a dynamic hypothesis for how a person might be affected by their social network. And we can cross-check that with what we pick up using smartphones based on recording who's around them, knowing something about the weight status of those individuals, knowing something about their contact patterns from the phone, we could pick up elements of contact and try to tease out elements of influence there. We could ask what exposures or ideations are associated with relapse in terms of lack of adherence to a chosen a level of physical activity, for example. What things might trigger failure to continue with a physical activity regimen. Think about for tobacco-related disease. To what degree is relapse to smoking affected by interactions with other smokers or vapors? This is something that Kurt and Narges have been looking at, or by exposure to pro or anti-tobacco messaging. Just like we did here a few slides back, where we could track exposures to non-home cooked food, we can do a similar thing. In fact, we have done a similar thing for exposures to tobacco messaging, and we can ask, to what degree is that associated with risk of relapse? Again, a recurrent events analysis, such as being led by Arash, can be useful here. And we can use timelines such as as what we saw earlier with exposure to home and food in this other area as well for tobacco. For environmental epi, we could ask, to what degree does exposure to particular environments explain occurrence of coughing and coughing and wheezing? For mental health, how does individual reported stress, depressive symptoms, or indicators of depression, the sort of things we can pick up through changes in mobility patterns, GPS, Wi-Fi, changes in sedentary behavior, changes in socialization patterns, changes in stress levels as reported by smartwatches through combination of tools such as heart rate variability and electrodermal activity. How does that, for example, vary with physical activity undertaken by a person, by social contacts or medication use? How does it vary with clinical contacts? These are the sort of things we can try to probe when we have these added data sources. And similarly, I won't go into it, but for communicable illness and health service delivery. Okay, let's talk about this next one, enhancing the speed, the reliability, and the depth of learning from implemented interventions. So my argument here is, I articulated it earlier, I'll repeat it, we won't spend that much time on it, but the idea is by virtue of being able to examine not just blunt outcomes of an intervention, the broad impacts on obesity levels or broad impacts on physical activity, broad impacts on chronic disease outcomes. The fact that we can examine many measurands along particular causal pathways, that we can tease out sedentary behavior from physical activity, that we can tease out the ways in which social networks have been changed versus exposure to built environments, we can secure better learning from the interventions that we undertake. We can learn more deeply, more reliably, more quickly from interventions. And the important thing here is, regardless of whether an intervention is as a whole successful or not, we can learn from it and render what has been a failure as an intervention into a success for learning. So you can imagine a situation where we're dealing with a set of health outcomes associated with move to mixed environments. This is an area explored by the Moving to Opportunity study in the States, for example, and we were privileged to be involved with Jeannie Brooks-Gunn and her group at Columbia Teaching College on looking at, as being part of a randomized controlled trial, looking at housing vouchers for moving individuals from poor neighborhoods on the one hand to mixed income neighborhoods on the other. And traditionally, the literature on this had noted certain outcomes. And the outcomes were very interesting. They're very thought-provoking. And they stirred a lot of speculation. They noted among teenage boys gains in terms of health improvements by for girls, lowered obesity levels. So healthier outcomes, lowered pro-criminal involvement and higher rates of high school graduation in teenage girls. In teenage boys, the impacts on obesity levels were unclear. I believe it was not statistically significant. Very, very small impacts. I believe there was a worsened chance of high school graduation and worse chance of pro-criminal involvement on the part of the high school boys. And this led to a lot of questions in the literature. Why was this the case? What might be going on? And as you can imagine, there's many hypotheses that could be brought to the fore. Let's just concentrate on obesity levels alone. Some researchers might posit that by moving to mixed income neighborhood, there's greater access to ball courts, walkable sidewalks, other amenities, and that those lead to increases in moderate to vigorous physical activity that can lower BMI and thereby obesity levels. Other researchers could point to the fact that there's greater perceived safety, particularly in the part of teenage girls, and therefore more moderate to vigorous physical activity. So it's not so much the amenities by that hypothesis, but the safety of it. In other cases, it's the general walkability of a neighborhood, the fact that there are sidewalks around, and decreases in sedentary behavior that might be big factors in implementing BMI. So there's a lot of speculation, in short, about these mediating factors that could be brought to bear. Other researchers had hypothesized that actually what may be going on is not so much mediated by physical activity, but it's actually by their eating habits, for example. It's by the fact that they spend, the teenage girls, with their social networks being fragmented by moving to a new neighborhood, they were actually spending more time at home. Their extra familial social networks, the networks outside the family, were greatly reduced by moving to a new neighborhood. They didn't know a lot of people, so maybe they spent more time at home and they ate more of mom's cooking rather than eating out at fast food restaurants in the area, and that led to improved healthiness of diet. Maybe that also led for them to have better associations, less risk of criminal involvement, and they were studying more, and therefore higher likelihood of high school graduation. Others pointed to school quality as perhaps leading to better school performance, or the availability of healthy foods. Perhaps in this new neighborhood, caregivers were able to seek food at grocery stores rather than at convenience stores, and that impacted healthiness of diet, and that rippled through to BMI and obesity levels. And we could look at those hypotheses, and traditional data sources provide some information related to them, but often what we have reliable understanding of is limited. So we know that people's self-reporting of their diet on traditional instruments can be challenging, and reporting of certain types of physical activity and sedentary behavior in certain cases can also be problematic. So here we do have some indicators of what may be going on, but a lot of these causal pathways, at least there can be reasonable doubts as to the degree to which we're really accurately probing what's happening along these causal pathways, at the degree to which we can pick up reliable indicators about what's happening along several pathways. By contrast, with big data, with aspects of this mobile data collection, we can actually pick up a variety of factors here. We can reason about the actual observed sedentary behavior day in, day out. Moderate to vigorous physical activity. Think about smartwatches and their ability to measure things. The amount of time they spend at home. We can pick that up with GPS and Wi-Fi. The likelihood of traveling to old neighborhoods. This was postulated as a reason boys might be getting in trouble with the law because they're going to their old neighborhood and spending time in the hood without parental supervision. Healthiness of diet. We can ask people to take photos of their food and potentially use point-of-sale records to figure out where they're actually eating. And we can figure out, are they going to grocery stores or to convenience stores in the new neighborhood? In short, by no means is is mobile data collection a silver bullet here, or panacea, but we get a much bigger picture across multiple pathways about what might be happening. And by linking with other data sources, for example, the location of grocery stores, the availability of recreational space, walkability indices, we can start to better tease out which of these causal pathways were actually improved by the intervention and for which subgroups. To what degree for teenage boys was sedentary behavior changed compared to teenage girls? To what degree were the teenage girls really spending time at home compared to their brothers? And to what degree is moderate to vigorous physical activity going on compared to changing in the healthiness of diet? And we have physical measures that can stand up to greater scrutiny and in which we can have greater confidence. I will note, just as a pointer to later discussion, that learning from these measurements, learning from observing which pathways have been changed, can be greatly enhanced yet by comparing with a dynamic model that also represents these pathways. We can actually learn more effectively across both sort of areas. Okay, let's talk about going down to the for the different health areas. You know, we can ask for obesity, to what degree has this lifestyle intervention really changed sedentary behavior versus moderate to vigorous physical activity versus dietary intake? Which of those has it changed for the better? How about in intervened upon groups? How about those non-intervened upon groups, but those that are potentially influenced through social networks? You know, other people in the same family who might be affected by the primary caregiver's changes in their cooking habits, for example. These are not things that can be always teased out into an intervened upon group and a control group in a very neat way. And we have a chance of picking up the ripple through effects between groups that have been actually intervened upon, you know, part of cooking classes or part of health promotion initiatives versus those who are merely exposed indirectly to the effects of those. And things like mental health, we can ask to what degree does the effect of a mental health intervention, for example, reduce risk of suicidal intervention, stressors, and adverse interaction between a patient and those around him. We can actually probe the intervention effects, you know, at a micro scale in a way that might be really difficult using only occasional survey instruments delivered long after the intervention or delivered soon but not in an ongoing fashion. As we'll see, the type of information that can be picked up on these mobile devices can often elicit this sort of information in a quite lightweight way using ecological momentary assessment. Let's talk about a few other things here. We can better understand how the choices people make are affected by their environment in terms of their health behavior. So we can look at, for example, the degree to which smoking and vaping on the part of an individual might affect each other. This is the type of work that Arash is involved in. But more than that, we could start to look at how my choice to use one of these modalities or another is a function of others around me engaging in that same behavior. And indeed, we have data collected by Ethica that looks at exactly that, where people report use by others around them, and we look at how that influences choice of technique. We can look at how geography changes things. Where did someone smoke versus for that same person, where did they report vaping, for example? What hour of the day were they smoking, for example, versus vaping? And you know, in different areas, we could try to understand the choice consequences based on the surrounding context. So how does occurrence of certain types of physical activity or physical activity at all vary with the built environment and the type of food consumed with the food environment? How do these choices vary in the context of distance, price, and food type? How does my likelihood of going to a grocery store depend on the distance in my activity space from a grocery store, for example? We can start to probe these with physical measures involving things like GPS and Wi-Fi to identify identify actual empirical movement patterns. Okay, so I'd like to highlight the final one of these, where I said that mobile data collection can also support broader understanding of the texture of day-to-day life for participants. Now that sounds kind of diffuse, and I would just argue that there's many types of questions where, when it comes to understanding a person's self-care, adherence to clinically given direction, care seeking, there's a lot of patterns which are reflective of their broader life context. So when it comes to mental health, a lot of what is going on in their life outside the clinical context has a shaping influence on their mental health outcomes. So for example, to what degree does occurrence of physical activity in a person following a physical activity promotion relate to different levels of turmoil in their life? You know, if they're in a situation where they're bouncing from relationship to relationship, or where they're having trouble meeting ends meet, working multiple jobs, we might expect a rather different set of challenges than for someone who's working a 9-to-5 job, fairly well off, in a stable marital state, and in a stable financial state. You know, to what degree does care seeking on the part of an individual, say for receiving antiretrovirals for managing HIV, depend on the turmoil in their lives, the context of their external life, how mobile they are as a population member, if they're popping back and forth between reserve and city, if they're out on the street as a homeless individual for some of the time. How does that impact their clinical care presentation, and how does it impact their likelihood of managing their condition? You know, to what degree can we predict clinical care outcomes, or at least better put someone, based on quickly measured characteristics of their life, put them into certain clinical care categories that might better accommodate the challenges in their particular lives? You know, we might ask, how does occurrence of hand washing compliance in the context of nosocomial infection, the context, say, of a long-term care facility or a hospital, how does the likelihood of a given staff member there engaging in hand washing reliably vary with work pressure by time of day? You know, how does personal protective behavior, for example, with respect to the flu or with respect to nosocomial infections such as West Nile, vary with aspects of their behavior and mixing? And you know, how does the extent of personal activity vary with experience of stressors or suicidal ideation? You know, to what degree does measured mobility or interpersonal churn and turnover versus stable relationships affect clinical care outcomes or suicidal ideation on the part of a patient? So that's an example of some of this kind of challenges of day-to-day life. Having a better understanding of person's stories. Some of the most powerful stories I've heard in that area from clinicians who tell me about, you know, the fact that they tried to manage clinical care outcomes at a positive level to certain patients, and they struggled because certain patients who they thought would respond positively to care regimens were not meeting the clinical care goals. And it was only after they burrowed down into understanding that patient's life, to their particular stories, their particular struggles, that they started to have a picture of the real challenges, and realized that while they had been trying to manage it one way, they really needed to manage that relationship another way. And I think it's a lesson that can apply in many areas, that the interventions we design can be much more effective if we can understand some aspects of the texture of people's lives. Okay, so a few conclusions. Sensors, as we've noted, are increasingly ubiquitous, and commodity sensor-bearing devices can serve as dual, versatile sensors. EMA, so it's the ecological momentary assessments, these micro questionnaires and crowdsourcing platforms, And diverse communication mechanisms like Wi-Fi, Bluetooth can support deriving context, interpersonal contact, and location. Coupled with models that we'll be talking about, sensor data, this is a whole bunch of different types of models, can offer significant and complementary health insights. And I think there's particular benefits in the area of learning from interventions, whether successful or not, learning more quickly about why, being able to come closer to reasoning at a mechanistic level about what is going on, not in terms of raw outcome indicators alone, but about the causal pathways that mediate whether the intervention, how much it succeeds along certain sides and how much it fails. And by succeeding in that learning, we can arrive at more reliable intervention instruments. Okay, so those are all of my comments for the presentation. Any comments or discussion we want to put to the fore before we dive in back to hands-on use of the Ethica system for the afternoon here? And discussion of some of the data streams that we're going to be deciding on for your studies. Any questions or discussion? Oh, Amin has signaled to me that there's phones that are ready over there. There's a phone for anyone who wants one. There's a phone to be claimed from Amin. And I believe it's free of charge.
No, it's
Yeah, okay. Yes?
Do you have the other Samsung phone that Cook brought? Is there any more left?
I give those to, I let Kurt keep them. I think he was handing them out.
Okay, sure.
Yeah. Okay. Any questions, comments?
There's coffee outside.
Oh, there's coffee.
Getting
Okay, coffee has been delivered. Mohammed, I noticed, just as a point of note for future days,
Sure.
I think someone asked me a prescient question before lunch. They asked, should we take the food in from the hallway? And I said no, and I inspected the food before going to lunch. I also inspected it after going to lunch. And whilst we were at lunch, the food disappeared. And so we might look into getting some refresher food sometime if someone can help out with
I
it.
just for the afternoon?
Yeah.
I just did.
Okay, great. Good. Okay. Any discussion? Comments? Okay, we're going to engage in some hands-on work. Then now that we have this break, do people want a 5-minute break for health reasons?
That can help.
Okay. Okay, so 5 minutes, and we'll change gears here. And I think Mohammed will be presenting for some of the afternoon, and I will be as well. Okay. Great. So we're gonna. After the break, we'll go through defining a study for the first time. You'll see how you can create a new study. And we will further then talk about some of the primal choices to be made in the form of the questionnaires, in the form, of data streams to be enabled for that study. And we'll talk about the 3 types of data collection Ethica supports: questionnaires, proactive self-reporting via buttons, and this passive data recording via sensors and background monitoring of other sorts, such as communicational behavior and app use. Okay, so we're going to take a 5-minute break, and we'll switch gears. Oh, I should note the videos from this morning are up on the YouTube site for anyone who wishes to avail themselves of them. Okay, great. Okay, so cancel here. Good. Okay. Great. Okay, capture. Okay. Okay.